Hello, everyone. We're very glad that you could join us for this very intriguing presentation today on blending behavioral health and primary care benefits, barriers, and implementation strategies. My name is Phoebe Nelms. I'm with Hybrid Solutions at Morehouse School of Medicine, and we're very, very glad you could join us for this training. Our presenter today, we're very delighted to have him, is Ed Johnson, LPC, LACS, MACCS. And just to tell you a little bit about his credentials, he has a bachelor's degree from Auburn University and a master's degree in clinical counseling from the Citadel. He recently retired after working for over 35 years in the field of addiction treatment and recovery, providing direct services to individuals with substance use disorders and co-occurring disorders. In his last position, he served as the Associate Director for Training and Technical Assistance for the Southeast Addiction Technology Transfer Center, located at the National Center for Primary Care, Morehouse School of Medicine in Atlanta. He has been providing trainings in addiction treatment, prevention, and recovery for over 30 years. And for the past 40 years, Ed has been a person in long-term recovery. He is currently credentialed, licensed as a licensed professional counselor, licensed addiction counselor supervisor, master addiction counselor, a certified clinical supervisor, and certified peer recovery specialist. So we are indeed honored to have his long years of experience represented in this educational material. Ed, take us away, please.
All righty. Thank you so much, Phoebe. Yes, I am excited to be here. This is a topic from experience. Have it's the field is moving in that direction. We're going to be spending, and I think that's a very good thing, on a bunch of different levels, and we're going to talk about that, among other things, today. So let's move right along. Some objectives that at the end of our time together here, we will hopefully have accomplished. Um, First off, we're going to talk about, and even though I think, the whole topic of blending, and I've deliberately, most of the literature talks about or uses the phrase integrating primary care or integrating behavioral health into primary care. I sort of prefer using the phrase blending because that is in essence and we'll get into this as we move along, that's what works. It's not, it's blending to me implies a more subtle dance than just integrating. And so that's what we're going to be talking about here. But first and foremost, we're going to talk about the benefits. Why should primary care practices, why should primary care physicians think about blending or incorporating behavioral health services, if you will, into a primary care setting? What is the pluses of that? We're also going to be talking about, because I think it's important to also acknowledge, what are the barriers? Why haven't we done this sooner? Why are people reticent to do it now? And when people do try doing it, what are the things that seem to function as a monkey wrench in that whole process? Then we're going to be talking about a bit of, okay, so you decide you're going to move forward with blending behavioral health into your primary care setting. How do you do that? What kind of resources are available to tell you how to do that? What are some of the the potholes that you might want to be aware of before you move into that to doing that? Just a little bit of background here. I think it's important, and this shouldn't come as a big surprise to anybody, that the healthcare system in the United States has historically had completely separate systems of care for issues of the mind and issues of the body. They are viewed. It's like two major league silos. One thing too that I'm going to talk about because it's equally as important to the whole topic of integrating behavioral health into primary care settings, is the fact that the systems of care for mental health and substance use disorders have also historically been separate, and they still very much are separate today, and that's problematic. Um, One of the issues too is that, and things are changing, but one of the issues too is that primary care providers, for that matter, most um, medical providers receive little to no training in mental health or substance use disorders as either part of their medical school residency or internship. They just don't. And we'll talk about some of the issues with respect to that. One thing too is that even though, and we're talking, I want to say back in 2008, it was under the um, President George W. Bush, but the Parity Act was passed, and the Parity Act basically mandated that health insurance companies reimburse behavioral health conditions at the same rate that they did medical medical conditions. And for a bunch of different reasons, that has been a long, drawn out process. Some states have been, and health insurance providers have been more um, rapid and more compliant with implementing that. Others, it's taken a while for them to get on board. Um, and also, along the same lines, just the reimbursement for substance use disorder conditions as opposed to mental health. Mental health is routinely still reimbursed at a higher rate than substance use disorders. Um, so when we're talking about what are some of the benefits, and something that I and this is just a casual observation. I think most folks, most healthcare providers are indeed aware of the issue of integrating, blending behavioral health services into primary care. It was one of the issues that really got a lot of push with the rollout of the Affordable Care Act under President Obama, um, because all the research very clearly demonstrates that on a whole bunch of different levels, it's more effective than having two separate um, systems, if you will. But some of the benefits, it's important to understand this that with with incorporating behavioral health, with blending behavioral health in with primary care, it sends a very positive message of the importance to both physical and mental health when we're talking about the whole concept of whole person health, which all of us, it's like also the whole issue of shifting from prevention, if you will, disease prevention to wellness, to wellness promotion. Because again, it all blends in together. One of the things too, that is a benefit is this next bullet here, that when we're talking about coordinated or collaborative care, you end up one of the things that one of the benefits is that there's a significant improvement. The two most common mental health disorders are, in fact, depression and anxiety. And it's one of those things that you, we, um, when behavioral health is blended in with primary care, the outcomes are much better. All right. And by outcomes much better, we're talking about sustained reduction in sympathy, in symptoms, and increased level of functioning. which again are the goals of both primary care and behavioral health care. One thing too that we know is that in the whole context of increasing access and increasing reducing um, um, disparities with underserved communities, that co-locating and blending behavioral health and primary care um, increases the benefit to underserved populations. And there's an additional part to that I'll go into in a little bit. One thing too, in this next bullet here, in a few minutes, and this is sort of a little taste here, in a few minutes, we're going to talk about one of the significant barriers to not just blending behavioral health in with primary care, but also the whole issue of treatment for behavioral health issues and substance use disorders is the whole issue of stigma, that individuals who have those conditions feel, or the and so anything um, that we can do to help reduce that stigma is a positive. It's a win. And one of the things that again research has clearly demonstrated is by having behavioral health services in a primary care setting, it significantly reduces the stigma and the reluctance of individuals to seek care for those conditions. Um, One of the things too is that when the whole person is treated, um, and by that I mean behavioral health, the mental, the body and the mind are both treated the same, there is an increase in patient satisfaction, um, a significant increase in patient satisfaction. And the good news with that also is that that results in patients staying at one practice instead of moving around. And it also makes it more likely that they're going to positively recommend the practice to their family and friends. So, one thing too, and this definitely really came to the fore um, during COVID, was the issue of care team burnout, of healthcare providers being overwhelmed, and one of the deals too of blending is that it does have a positive impact on the satisfaction of the care team and their well-being. And part of that has to do with, let's go ahead and zip this in here, um, is the fact that there is such an impact on, say, for example, the treatment of chronic medical conditions, which again are overwhelmingly present in underserved populations as far as type 2 diabetes, hypertension, high cholesterol, asthma, all of those. And by addressing, and frequently those medical conditions are severely impacted by an untreated behavioral health slash mental slash substance use disorder. So if you can address the substance use disorder and or mental health condition, it's going to improve the medical conditions, which again, all of us in the field of healthcare, we want to help people. We want to help people get well. And it hurts. It's frustrating when we're not able to do that. And that also contributes to compassion fatigue and by extension burnout. One of the things too is this whole issue of again, when you treat the whole person, um, you also, again, there are the positive outcomes. Um, that go along positive outcomes. And it's important to understand when I say positive outcomes, I don't mean just positive behavioral health outcomes. I also mean positive medical care outcomes. Okay. And that's it's important to make sure that we understand that it's not just, you know, um, it's both positive outcomes for both of them. One of the deals too, and especially for those folks who are on the webinar who um, whose practice is located in a more rural setting, y'all are very well aware of the fact that the more stuff you can consolidate because transportation, um, rural areas, transportation, it's a big deal. One of the things this was quite a few years ago when I was doing direct services. I was on the Ryan White um, advisory board at the medical. I forgot to tell y'all, I'm not in Atlanta or Georgia for that matter. I'm over in South Carolina. I live in Charleston. So um, it was the Ryan White Clinic here in the Charleston area was located at the Medical University of South Carolina. And it was at one particular meeting and the program manager was very cranky about the fact that and pointed out the fact that we call these people and remind them of their appointments multiple times and they still don't show up and it makes no sense and then they show up at the emergency room and it's like, why do they do that? Why don't they keep their appointment? Makes no sense at all. And I just sort of looked at her and I called her name and I said, it makes perfectly good sense to me. The bus system here in Charleston stinks. It's like it's a whole day extravaganza to come to an appointment. Or if you have a friend that can take you, they usually can't, they're working and they can't take you during the day. They can take you to the emergency room at night, but they can't take you to an appointment during the day. It's about the logic or the ability. It has to do with transportation. They're not doing this just to you know work your last good nerve. It has to do in addition to the fact that a lot of these folks don't have jobs that have sick leave. So in order for this whole day extravaganza to keep an appointment when they're feeling fine, they have to choose, do I keep the appointment and not make money for that day? And that's going to impact my ability to buy groceries for my kids. What's more important? Again, so it's this whole, the more things that you can consolidate, the more services that you can consolidate and truly make a one-stop shop, the more you're going to have as far as people keeping their appointments. So yeah. Um, One of the deals too is, again, and this ties in very closely with it, is when you combine um, physical and behavioral health care, you end up closing the gap between, what we know is the prevalence of behavioral health conditions and people actually receiving treatment. Okay. That's a significant issue. Um, Last but not least, and this is a biggie, is that when behavioral health and medical and primary care are in the same location and you've got a care team following the individual, you have the rates of emergency department visits, of hospital admissions, and of intensive care stays decreases. And I think we all know that those three conditions um, are very costly, in addition to the fact that the goal of everybody, be you behavioral health or primary care, is um, to intervene before things get to the point of requiring an emergency department visit or requiring a hospital admission. It's like you want to get to it before it reaches that point. Okay? Um,
Can I interject?
oh, please do.
This is
Absolutely.
this is great. The benefits outlined, some of the things that really I keyed in on is that mindset of wellness promotion versus disease prevention. that
Yes.
happens with the blending and
Hmm.
coordination of care. And I was really struck by your last statement about the overall cost to healthcare being impacted by intervening earlier
Hmm.
and managing the whole person.
Exactly.
Um, and then I hadn't thought about the impact on staff when there's a greater feeling of fulfillment in
Hmm.
managing the whole person and seeing better outcomes on both behavioral health and physical health, that would give them an increased feeling of satisfaction
Yes.
and effectiveness, which helps tremendously to reduce burnout. So
Absolutely.
a wonderful list of benefits.
Yes.
But
Thank
it's
you.
not all peaches and cream, is it?
No, it's not. And we're going into, and again, like I said, it's one of those things that when I don't, if any of y'all have ever experienced, any of the folks on in the training have ever experienced being in an organization that goes through a major restructuring and a major change of the way you do things, there's one of the dynamics that, and I mean, and it's part of implementing change in an organization. But one of the things that frequently happens is this mindset that in order to make everything go smooth, all you have to do is provide enough education and information. And while that's a part of it, it's also important to understand the dynamics of the employees, their feelings towards management, their feelings towards, is this going to benefit me? Is it going to cause me to have more work? Those kind of deals. And when we're talking about barriers to integrating, to blending behavioral health and primary care, those are some of the things that come into play. Um, some things to think about. And it's not just, it's important to understand that I'm going to get into in a few minutes the barriers in the primary care setting, the staff in the primary care setting, and some of their particular barriers. But it's very much important that we understand the barriers on the behavioral health side of the house. Um, One thing, and this is some states, it's sort of interesting. Um, and I've lived in South Carolina 41 years, and I'm 71 years of age. So I've lived in South Carolina over half my life. It's home. But we do some things over here that sometimes cause you to go, hmm. Um, and one of those things is we are the only state, and we almost made it. We almost made it this past legislative session, but it got run off the tracks at the last minute. We are the only state where mental health and substance use disorders are in two completely separate agencies. Okay. Um, Even in states where mental health and substance use disorders are in the same agency, as in Georgia, um, um, with the the Department of Behavioral Health and Developmental Disabilities, they're still separate. Okay. And while that's somewhat problematic, it goes down further in in organizations, actual frontline organizations, where you have, they might be in the same building or they might be in the same agency, but they're not blended together. Okay. And we're going to see in a few minutes when we talk about the whole issue of integrating behavioral health into primary care, that this on the same care team is a critical component in the effectiveness of the blending. Um, so it's like, yeah, they're both in the same building, but they're still in separate parts of the building. All right. And that's challenging. One of the deals too is that um, routinely, um, mental health providers are very, very, very proficient in um, mental health, in identifying and treating mental health disorders, but they aren't familiar with substance use disorders. They're not familiar with um, how to work with somebody who has a substance use disorder in conjunction with. So it's like now the good news is that the co-occurring clinicians who are proficient in co-occurring treating co-occurring patients is increasing. But again, it's sort of like the whole issue with behavioral health and primary care integration. It's a process, and it's a process that when you're blending two separate service systems into one, it's challenging. Um, and it's interesting, and because one of the dynamics that I mean, and luckily here in Charleston, the um, county alcohol and drug um, treatment center and the mental health treatment center work very closely together. Um, but in a lot of other counties, and some of you might be familiar with this, it's like what happens is what I like to call patient ping pong, as in somebody shows up at mental health, and in the course of the assessment, what comes up is that there is a substance use issue. And it's like, oh, we can't touch you. You've got to go over to see the folks at alcohol and drug and get your alcohol and drug treatment taken care of. And then you can come back and see us. And the folks at substance use do the same thing. Oh my gosh, you've got a mental health issue. Oh, you got to go and get stable on meds before we can do anything about it. And so what ends up happening is what we know, I mean, we know very well that what works best is when they're both treated at the same time and all. But again, which is the same dynamic with chronic medical conditions and behavioral health issues. One thing too that's also an issue is, and we'll see this when we talk about integration, is this whole issue of, okay, you've got a behavioral health counselor, be it mental health or substance use, and they're used to having 1 hour appointments, boom, 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 seeing folks. And that's not the model that works real well in primary care settings. It's one of those deals that a more abbreviated, brief intervention in that setting. It's sort of like the same concept of what works best. And it's important to understand when we talk about integration, it's sort of like, again, in primary care, you have somebody who has major cardiac issues. Primary care is not going to be able to address all of those. However, primary care can identify them and evaluate the level of severity, and if needed, refer them to a specialty practice that can provide more intensive treatment. And it's the same kind of dynamic with respect to somebody who has a behavioral health issue. Lower level, less severity, that can be handled in, it's the same kind of deal. And also, what behaviorists can be effective with in primary care settings is just a simple kind of dealing with stressors, that helping somebody to relieve the healthcare provider or work with the healthcare provider to help somebody with stress management and life skills kind of stuff that again will improve the outcomes. One thing too is that, and this was something that is really was in glaring relief. Um, there is a shortage of behavioral health treatment providers, be they alcohol and drug or mental health, especially at the level of um, public or Medicare and Medicaid providers. Um, and then, of course, one of the last barriers too with in the behavioral health world is that again, in a lot of places still there's less robust insurance coverage for substance use disorders and mental health than there is for primary care. So as a result, why that's a barrier is because clinicians, be they mental health or substance use, can earn more in private practice than they can working at an agency. Okay. Um, so moving into With respect to the primary care setting, um, I just had to pick up for this. We're going to talk about the elephant in the middle of the living room. Um, and since an old joke is that in late stage alcoholism or alcohol use disorder, when somebody is experiencing delirium tremens, they it's frequently said they see pink elephants on the wall. So I just had to pick a pink elephant to sort of toss this in there. But it's important for starters, the whole discussion of behavioral health, the whole discussion of mental health, primary and substance use disorder treatment, and folks who have those, the elephant in the in the middle of the living room is the stigma that is attached to mental health and substance use disorders by society at large, and that's very important. Um, so just backing up a little bit here, when we're talking about stigma, what exactly is it? Well, it's a mark of disgrace or reproach. It's a stain. It's not good. Stigma is never based on fact, but it's rather based on assumptions, perceptions, and generalizations. And most importantly, you can't, stigma can be impacted and can be lessened by education, but it's important to understand in the whole topic of behavioral health and the whole concept of education, a lot of the stigma, and a prime, especially with substance use disorders, a lot of the general of society, people in society's negative feelings about substance use disorders is based on personal experience. It's based on personal experience with a family member or a close friend who may have had a substance use disorder or severe and persistent mental illness that they weren't, the family member was not adherent to treatment. Um, and even though you provide education to folks as far as, okay, this is a medical condition, this is why they're doing what they're doing, that kind of stuff, it doesn't reduce the pain and it doesn't reduce the emotional experience of, say, for example, growing up in a family where, as a child with a parent or a sibling who had an untreated mental health, mental illness, or substance use disorder. So education by itself doesn't reduce stigma.
That is so true. And it does, I think, impact this in that sometimes it takes years before a person
Mhm.
is actually diagnosed.
Exactly.
And so that gap in between when there's this feeling of
Exactly.
helplessness.
Yep. That is so it. That is exactly it, Phoebe. It's and also internalizing what is it that I'm doing that is causing this to where, if I were just a better X, Y, and Z, I could convince them to not be this way. And it has nothing to do with that. But feelings are reality, especially when you're young. Um, they just are. The deal with, and this is where we get into it. The two things that most affect stigma are if society perceives that the person has control over the condition. Okay. And secondarily, the perception if it's their fault that they have it. And especially when we're talking about substance use disorders and the emotional toll that they take on families and loved ones and employers and all of that stuff, the perception is that yeah, it might be a medical condition, but it's a medical condition of choice. You're the one that started drinking and using drugs. It's your own darn fault. And if you really wanted to, you could control it. Well, we know that, at a certain point in time, um, early on, and depending on the substance they're using, there might be a certain level of control. But after a certain point, it's not there anymore. And we know the part of the brain that's impacted. And it's one of those deals that it can't be controlled. However, and the interesting thing too is, and this is something that is very interesting when you compare substance use disorders and type 2 diabetes and high blood pressure. All three of them have genetic components. All three of them are impacted by behavior as far as the development. In other words, um, behavior, or excuse me, diet and exercise impact if somebody has a predisposition to, say, for example, high blood pressure or type 2 diabetes. Diet and exercise are going to impact whether they go on to develop those conditions. Same way with substance use disorders. Somebody might have a predisposition, even though, with the predisposition part, depending on, we know now, which is sort of cool, it's the concept of epigenetics, that people have the gene, but something has to happen to trigger it. And one of the things that triggers it, we know, is trauma. But this is a real quick um, study that I like to point out as far as with respect to people's um, perception. And one of the things I think everybody who's watching this will agree that when somebody hears the phrase drug addict or drug addiction, they get a mental picture in their mind, and it is not pretty. Um, but if you look at this survey, um, basically 90%, and the black line is substance use or drug addiction, the gray is mental health. 90% of the people that responded said they would not want somebody with drug addiction marrying into their family. Now, it's interesting that society as a whole makes a distinction between drug addiction and alcoholism. So I'm guessing, because they specifically said drug addiction, that maybe they might not have had such hard feelings about if somebody had an alcohol problem. But if you go down the list here, all of them, they wouldn't want, 60% wouldn't want somebody with a mental health condition marrying into their family. Um, the All of these things oppose equivalent insurance benefits. Again, 43% for substance use, 21 for mental health. The only ones, it's interesting, the only one that mental health beats out substance use is that recovery is not possible. And it's not by much. But again, why this is important is going to become real clear in a few minutes. Healthcare professionals, because they don't routinely get a lot of formal education and training on mental health and substance use disorders, that's just beginning to happen. They have the same feelings and the same biases and the same understandings of substance use disorders and mental health conditions that the general public does. It's important to understand too that mental health and substance use disorders are stigmatized. That causes discrimination. They're treated differently, and it also causes internalized shame and people being blamed for their behaviors and their condition. Um, it's important to understand um, when we're talking about the whole, you know, and structural discrimination as it impacts medical practices. Um, it's one of those things that because, and we'll get more into this in just a little bit, but physicians want the best for their patients. That's why they got into this field. And it's one of those deals because of not receiving a whole lot of training on substance use disorders and or um, mental health. It's like it's impacting the care, but they don't know how to deal with it. So that level of frustration, the separation of mind and body, less education about mental health and substance use disorders, and then there's the whole issue of lower pay. Um, One of the deals too is that patients routinely have had very negative experiences with healthcare providers. Patients with mental health or substance use disorders, especially substance use disorders. Um, Give you an example, a couple of examples. Um, I have colleagues, um, people who are friends in recovery, who are healthcare providers who have not and who work in emergency departments, and their colleagues in the emergency department do not know they're in recovery, primarily because they have experienced in the past where, say, for example, if there are any drugs missing, they are automatically the person that is assumed to have stolen them. It's one of those things too, that everything is as a patient showing up at an emergency department. Um, you're treated poorly. If you're a person of color with a substance use disorder and you show up in an emergency department, you are really treated poorly. Um, Again, because of not having the understanding. And there's another study that I'll go into um, in a second here. One thing too that's important to understand is culturally, mental health, talking about, having issues, you don't go outside the family to deal with them, and that's one of the issues too of, again, this shame, and how the individuals, I should be able to, they internalize, I should be able to control this. I can't control it, so I must be bad. Um, one of the deals too is, again, this whole issue of being able to access care for substance use disorders and mental health issues. One of the things too is this, you know, this deal, and I mentioned it a little while ago, about they'll be treated as a bad patient. And this is over the years. I worked with folks who had opioid use disorder, people who were being prescribed either methadone or Suboxone, and routinely they did not tell their primary care physician that they were being prescribed those, because the experience of a significant number of them was that they were automatically discharged from the practice, um, because they were quote unquote addicts. And again, and that impacts care. I mean, I have had more than one patient who had a health issue. Say, for example, one in particular comes to mind, who had sprained his back and didn't tell his physician that he was being prescribed methadone, and the combination of the medication that the physician prescribed with the methadone caused him to overdose. Um, he didn't say anything because he knew that he probably wouldn't get any medication for the pain, which was legitimate pain. Um, One of the deals too is, as far as stigma goes, um, is folks being concerned, patients being concerned about, oh my God, if I mention this to the doctor, is it going to, with childcare, with Department of Social Services, are they going to be able to access it and find out about it? How about law enforcement? If I tell the doctor that I'm using drugs, is the doctor going to turn me over to the police? Which, they wouldn't, but as far as, I would hope not. But again, it's concerns on the part of um, the patients. The thing, and this is the big deal right here. Again, in healthcare settings, stigma shows up as avoidance. Healthcare providers don't ask the question. Primary example, especially like here in South Carolina, um, and in a lot of we have, it's a ruling that if a woman is in the third trimester, and she tests positive for as a positive drug screen, it automatically has to be referred to the Department of Social Services. So OBGYN, they don't, they don't ask the question, and they definitely don't test for drugs, um, to avoid having to report. But more importantly, um, avoidance and not asking the question has to do with, it's like, okay, I ask the question and I get an answer. I don't know what to do with it, or who to refer to, or I don't know. And the beautiful thing is, and this is something we'll get into in just a second, is that there are things, when you talk about integrating, that being able to um, do the screening and brief intervention, the same ways, like every time somebody shows up at the doctor's office, always going to take their weight and check their blood pressure, to where if something's out of whack, they can intervene quickly, as opposed to waiting until the person has a heart attack or a stroke. Um, but the deal is too that, again, there's the perception of, okay, if I ask questions about suicidality or whatever, what do I do with that information? Also, the perception that people with mental health and substance use disorders are violent, which, yes, some are, the majority are not. Um, And then one thing too is the whole issue of liability. If I ask these questions, and I need to be able to provide the service to fix it. And if I can't, then I'm liable. So that's a concern with as a barrier. Also, this last one here is the whole issue of you've got a busy clinical practice. It's like, okay, I start asking these questions, not knowing what in the world I'm going to do with it. We don't need to take on any more stuff and all. And it's like, and who's going to ask the question? Is it going to be the nurse who's overworked? Is it going to be the doctor who's overworked? Who's going to do it? So those are all, again, barriers. So looking at it from the standpoint of integrating, it's important to understand, and we're going to get into this in just a second some more, but these are all organizations that have integrated care. Okay, now the levels of integration vary. Okay, but what does that mean? Well, say for example, at the Department of Veterans Affairs, when somebody shows up for an appointment, they're automatically, first thing, they're going to do a depression evaluation. And they're also going to ask the question, do you drink? Yes. How many drinks have you had in the last week? How many drinks have you had at one time? And depending on that answer, then they're going to, evaluate somebody, the beauty of which, again, the whole goal is to intervene before somebody's drinking becomes to the point of, um, they come in reeking of alcohol and missing their appointments and things like that. The Department of Defense, same thing. And gosh, I can't remember how many years ago it was, but HRSA um, provided funds to um, federally qualified healthcare centers to blend together. But again, the quality of that blending varies from center to center. You look like you had a question there, Phoebe. So I just
Oh, I'm just very thankful that you're sharing some good news. The optimism is coming back.
things are getting better.
Yeah, and
Got to admit they're getting better. They're getting better every day. They are.
awesome. And
They
I was,
are.
yeah, in federally qualified health centers, I just had an opportunity to look at some of the websites of some of these facilities, and I can see that there really is an implementation of the blending, that the resources
Mhm.
that they outline on their websites,
Mhm.
demonstrate that behavioral health is a top priority alongside primary care services.
Exactly. Um, they're actually, when we're talking about levels of behavioral health integration, there are three levels. There's first and foremost, which a lot of times is the most common, is what's called coordinated care. Basically, say for example, before the HRSA gave the funding to federally qualified FQHCs here in Charleston, we had a working relationship at the County Department of Alcohol and other drug abuse services. We had a referral relationship and all. In other words, basically, it's like the person was getting their behavioral health and their primary care services at two separate locations, but the two providers communicated and all. So, and they referred between folks. Then there's what we talked about as far as co-locating care. In other words, they might be in the same building, but they're still maintaining separate practices. They're still separate, health records. And then there is what is the gold standard or what is most effective, this fully integrated care. Okay, which basically, in a nutshell, is that the behavioral health and primary care practitioners act together with a joint patient care plan. And again, it's like the behaviors, and there are a couple of different models of this fully integrated care plan.
Um, in,
Yeah.
in one of our earlier conversations, when I was getting to know your length and breadth of experience, you mentioned the difference that these different levels of integration can make as far as an individual's keeping appointments and following through. You'd mentioned like just having both services in one location. I think you told me a story
I
about it.
did. I did. And the example was we were um, a couple of different examples that were sort of cool. One, alcohol and drug, we were located right next to the health department. The buildings were, walk through, we were the same building. Routinely, what happened, what would happen was the somebody would be identified at, say, for example, either the sexually transmitted infection clinic or the HIV clinic, and would be given a referral to come and see us. And the social worker would give us a call, but between when they left the second floor of the health department and made it to the ground floor of our building, they got lost. Um, Along the same lines of, we started having one of our at the Ryan White Clinic. We started having an alcohol and drug behaviorist there in the clinic, because they would refer somebody to us and it was a block away, but the person wouldn't make it. So it's one of those things that, and routinely, when I first started in the field, I worked part-time in alcohol and drug. And then I also worked at the health department doing what we call today screening, brief intervention, and referral to treatment. And it was beneficial on a couple of different levels. It was beneficial because, it's one thing you do an in-service once a month, and or a lunch and learn on, say, substance use disorders, and that's fine. But having me there in the clinic to where the providers could just casually ask questions or walk somebody from their office over to mine, increase the knowledge and understanding of the health department staff. And so it's those kind of deals. And it's one of those things too that routinely happened where, say, for example, because again, when we talk about lack of knowledge, this happened repeatedly where the provider didn't ask the right question of the patient, as in, do you drink? Yes. Well, how much do you drink? Well, not much. How often do you drink? Rarely. And their medication for their HIV medication wasn't working. Well, it wasn't working because what was really going on was they were drinking a fifth of vodka a day. But again, not knowing how to ask the question, and again, that fear of being treated differently. Um, so again, that's the benefits of again, you can walk somebody down the hall, that's the co-located care. But it's like when everybody is part of the same care team, and when you're sitting in treatment team or whatever, going over cases, and the behaviorist can add something to the or write something in the chart that the primary care provider is going to see, that's going to be an, oh my gosh, because it's the same health record that they have access to. Um, the two integrated models that are most commonly used are, again, the main one that is this primary care behaviorist model, and again, co-located and integrated. In other words, you've got a primary care behaviorist, all right, and basically they're doing evidence-based screening, and there is, in with the primary care, there's a warm handoff, walk them right down the hall. And again, because there's less, it's in a primary care setting, the which is one of the things we notice too. There's not as much resistance to talking. One of the things too is this, notice here, evidence-based behavioral treatments customized for primary care. In other words, shorter, they're timed at the same, to match primary care appointments. And notice treatment duration less than 6 sessions. So it's not long term. It's like the in practice, it's going to be short term. It's going to be short term therapy. If they need more, then they can refer them out to the mental health clinic or substance use. Now, this care management, this is where you really don't have a behaviorist there, but you still do. This is where, like, and I'll be honest with you, this is the model that a lot of times causes folks to get cranky in medical practices because basically it requires that somebody who's already on staff does the screening. So it's like a nurse or a med tech, somebody who's already on staff, already doing other things, does this screening, and then as needed, will refer them to a practitioner. This would last longer because again, it's one of these, this care manager is going to be coordinating more closely with the outside provider and all, and be working more closely with the patient to make sure the patient follows up and whatever. So it's a bit longer. One thing too about in integrated settings is taking advantage of telehealth with respect to limited availability of psychiatrists for specific psychiatric related med management is another benefit. One of the deals too, and when we're talking about integration, it's important to understand if your practice, if you're continuing or if you're considering doing it, there are a couple of things that are very, very important to do. First and foremost is you as the primary care physician, um, you need to make sure that you have buy-in and understanding from the rest of the staff, primarily because it's the support staff. Again, remember one of the issues with stigma that as far as that were problems for patients, the way they were treated. Um, if you have, you as the physician might be on board and think this is a wonderful thing. However, if um, your some of your nurses or your med, your receptionists do not like those people, it's not going to be positive. You've got to, you know, you've got to be, your staff has to be on board. And one of the things too is that, and an example of how things didn't work when buprenorphine first came out back around 2000. There was a specific X waiver, DEA X waiver that doctors could get to where they could prescribe it in their practice. Um, Probably for every 5 doctors that got that waiver, only one would actually see patients because there was such pushback from the patients, the other patients, or the perceived pushback that they didn't want those people in the lobby. So it's one of those deals that there's a lot of, there's issues of stakeholders that you need to be aware of. One of the things that I think, there's so much involved with actually moving forward with doing it. I mean, everybody, we agree that there are benefits. We understand that. We know that. We know that there are barriers. And the barriers are one of the benefits of, if you have a behaviorist on board, again, depending on that person can probably do a whole lot towards helping reduce the stigma. One of the problems too, and I mean, this was a problem that happened with a lot of the federally qualified, the FQHCs, was that because the physicians, initially at least, the physicians were prescribing um, buprenorphine for folks with opioid use disorder. That was the original purpose of it. But because the physicians didn't understand that, okay, so the patient tested positive for marijuana. You don't cancel their prescription for Suboxone because they have a marijuana positive. The two aren't related. They didn't understand. It's like the same way as you wouldn't stop somebody's blood pressure medication if they weren't taking it the way they were supposed to, or um, if they were continuing to eat a pound of salt on everything and not exercise. You wouldn't do that. So, physicians had to understand, it's the same kind of thing you would do for other chronic medical conditions. You treat it the same way. It's not a behavioral issue. Um, but, again, having that behavior is there. And part, again, one of the benefits of that this whole concept of integrating too is the fact that because the medical staff is better able to respond to the needs and the problems, and because they're learning new things, they feel more excited and feel more positive about that. This is where it becomes it helps with staff satisfaction because they're feeling like they're able to do more good. Now these are some resources. This one in particular, it's about a 60 page. It has a lot of wonderful embedded videos in it, but the Behavioral Health Integration Compendium, and it's put out by the AMA, and it is a wonderful, wonderful, wonderful resource for how do you move forward. Okay. Um, just for for if somebody wants to have, okay, where is this going on? How's it going? This is something, and the latest edition is from 2022. Um, but the state of integrated primary care and behavioral health in the United States. Um, and last, but definitely not least, this particular handout is I like this handout from the standpoint that it has a lot of all of the benefits that can be achieved, and it has all of the citations of, like 10 citations on the improved drug adherence for people with type 2 diabetes when they are also receiving um, treatment for their substance use disorder. So, um, again, and last but, and I completely went brain dead and didn't put it in here. The Substance Abuse and Mental Health Services Administration, SAMHSA, SAMHSA.gov. They have a special center on integrated care, and they have a lot of resources that are free to providers and folks that work in their practices alike. Um, so yeah,
Yeah,
oops,
it sounds like just based on the some of the things you shared with us, we might need to do a whole new training on how to overcome the stigma in for behavioral health
that
for primary care providers and staff. That was a very
we
interesting
we can do
um
that
thing you shared. Yeah.
if this might be something to get edited, but yeah, we could definitely do that.
All right,
Because
great.
I mean, I've done those. I have done those kind of trainings. And again, part of the challenge is, acknowledging the fact, the goal isn't to make people feel bad. It's to help people to explain things. And a lot of times,
Well, you
um,
said it. It's knowledge, it's education.
it's
And it's very cliche, but education has the power, and knowledge has the power to
mhm.
change,
Oh yeah.
perception.
And I mean, this is one thing too that um, being a person in recovery. I mean, I'm concurrently doing for Dr. Tyus with working with faith leaders and being available to answer questions. It's like, well, when did you know that you had a problem? Like, well, it was actually the United States Navy that realized that I had a problem before I did. Bless their little hearts. But this is the email address.
Well,
Um,
we want to thank you so very much. This was an amazing you shared a lot of very practical information. It shows the pros, it shows the challenges, and it shows that we should always keep this positive mental attitude about what
mhm.
is possible and
It,
finding the solutions,
yep.
especially with a rural focus. Maybe telemedicine is part of the
Mhm.
solution to increase access to qualified behavioral health providers.
Yes.
You just shared so many different things. So thank you so very much. And we look forward to maybe tagging you another time.
We can do that.